Good afternoon. Welcome to our webinar titled The Top 5 PCH Violations and Best Practices in Avoiding Them. The webinar is going to be about an hour and a half long, with the first hour being for the content and the last half hour for questions. Everyone attending the webinar is automatically muted, but questions can be asked during the webinar if you type them in on your screen. And in order to send a question, you go to the question pane of the control panel, which should be on the right-hand side of your screen, and use the drop-down menu and select either all, organizers only, presenter only, or the name of the specific attendee. And then enter a question in the provided field and click send. We don't see those right away. I just want to make you aware of that. But they print them out in another room and bring them into us as they go along. So we'll get the questions eventually. We might not see them immediately, but we will save them for the end. And we only plan to cover questions relating to today's topic of the top 5 violations. And any other questions can be directed to the operator support hotline or the regional office. And we'll give you the number for the operator support hotline at the end of the presentation. And we have one handout available today, and that's the PowerPoint. So it is available in your handouts on your screen there in the options menu. And if you open the options menu and then click on the plus sign next to the word handout, a box containing the handout will appear and you can access it there. All right, my name is Michelle Strouser. I'm the Director of Training and Professional Development for the Bureau of Human Services Licensing. And with me today is Dale Crow. He's the hotline manager. And we have Israel Springs as well, who is a Human Services Licensing representative in the Central Region for BHSL. Okay, today's webinar is being recorded again. To access the webinar and any past recorded webinars, you can visit our website at the link on the screen, www.dhs.pa.gov/provider/long-term care services. You click on that link and it'll take you to our website, and then you would scroll down to the general information section and click on the last bullet, general training information. And there you'll see the different choices, and there's the webinars there where you can click on webinars and it'll come up with a page that has all of our recorded webinars. Now our last one isn't up on there yet. We had a little bit of a delay in getting that to us, so we'll get it out there as soon as possible. That one had to do with incident reports. Okay, now we've been doing webinars about once a month, and we're going to try to keep up with that as long as we can. If you have any suggestions for topics, you can always email us and let us know if you realize something we're missing here that we should cover that we're not thinking of. And to find out about future webinars, you can join our listserv or keep an eye on the What's New section on our website, which is on the main page. And the link to join the webinar or join the listserv is also on the main page there, pretty close to the top of the page. And this webinar does count for personal care home and assisted living administrator credit, even though the top 5 violations we're going to talk about today have to do with PCH. Due to the similarity in the regulations, we feel it should count for assisted living as well. So assisted living administrators, feel free to count this training towards your required annual training. We're not issuing certificates, but just document the amount of time you're on the webinar on your training plan, with the other pertinent information about the webinar, such as the title and the date and the presenter's names. So our outline for today will be covering the top 5 most commonly cited violations for personal care homes and the reasons they're commonly cited, and best practices for staying in compliance with the regulations. And these top 5 violations are the most commonly cited, however, not necessarily in this order of occurrence. Okay, the first violation we're going to go over, top 5 common, one of the top 5 most commonly cited is 85A, which is sanitation, and the regulation is sanitary conditions shall be maintained. And we've listed some examples here of things we see that are common examples of this violation for 85A. And a lot of this information is also in the regulatory compliance guide if you need more information. But I just put a list down here of the things we see. I'll just go through them. Feces, which could be human or animal, could be inside the home, outside the home. If the front porch is covered with dog feces, or the yard is, where people walk is covered with dog or animal feces, that may be a violation, or of course in the home anywhere. Urine, human or animal, bodily fluids such as blood, mucus, vomit, rotten or spoiled foods in the home, the presence of mold or mildew, often in the bathroom or the refrigerator, kitchen, splattered foods and liquids in the microwave or refrigerator, pungent odors that could be the result of something unsanitary, extremely unclean surfaces of any kind. And I have on here shared glucometers in red, because this is where you would possibly receive a violation if it was found that the home was sharing glucometers between residents. So I'm going to turn it over to Israel, and we're going to talk a little bit more about best practices in avoiding the violations.
Good afternoon, everyone. When we talk about sanitary conditions, what we ask that you do is to not just leave that to your maintenance staff. It is something that is home-wide. We need to understand that everybody has an investment into being compliant. If you smell something unusual, don't just leave it to someone else to go find. Try and search it out and to see if it is the cause of someone's incontinence, being in a diaper too long. The main issue that we have right now, though, are shared glucometers. And most of our medical staff that work in our homes are coming from either a hospital setting or a skilled nursing setting. And in those particular areas, they are allowed to share or have a house glucometer. In personal care, that is a no-no. There are no exceptions. To prevent that from happening, best practice would be make sure that you have everybody's glucometer labeled with their name. Also, make sure the little packet that you keep them in is labeled. Also, make sure that whoever is taking the glucometer reading, record the reading shortly after it's taken rather than trying to do multiple ones and mixing up or transposing numbers. Understand if the numbers are transposed and don't match what is on the glucometer and the MAR, it is a violation. Understand that if you put somebody else's reading on someone else's MAR from someone else's glucometer, it's a violation. It is supposed to be accurate, and it's supposed to be done so that we should be able to take the glucometer and match it to the MAR. We do understand that you get busy, and sometimes you are tempted to say we can clean the glucometer. Because of the problems that we've had with the spreading of hepatitis C, the CDC has asked us not to go in that direction. And we feel that to better protect our residents that we are charged to take care of, that is something that we are watching very closely. We ask that each home monitor their own glucometers, put a plan in place that will keep you from, waiting for us to come to monitor. I tell you, if you understand what we are looking for, it makes it a whole lot easier for you to remain compliant. And if you have questions, you can call our offices, and we will be glad to assist you in any way to help modify your procedures where you are compliant.
Yep, Israel, that's a really good point. I think that one of the things that I like to emphasize as far as best practices and making sure that these kind of violations don't come up is that you shouldn't be waiting until we show up at the door or when you think that you're in the window for an inspection to look around and make sure things are clean. The QA process goes on year-round, and that's something that you need to have some sort of a committee or team that works on QA measures all year long. And that includes things like your sanitary conditions, among others.
Right, and having good policies and procedures regarding what staff are supposed to do, who and what, where, when, and why, in your policies and procedures, and having staff training on the policies and procedures is very important as well. Ensuring that the staff understand the reason why they're supposed to do things a certain way goes a long way. Like with shared glucometers, a staff person might not understand why it's important that you don't share the glucometers between residents. And it might be convenient for them to do that, but if they understand the reasoning behind why it's prohibited in personal care homes, maybe that would make them more likely to comply with the policies and procedures. So that really empowers the staff to know why they're doing something, and then they'll put forth the extra effort to make sure it's done according to the policies and procedures. Okay, let's move on to the next. Next, we have 185A, accountability of medication and controlled substances. And the regulation is the home shall develop and implement procedures for the safe storage, access, security, distribution, and use of medications and medical equipment by trained staff persons. And I listed some examples again for this regulation for types of violations you might see, things that could possibly go wrong under 185A. The first one I have listed here is missing elements in the policies and procedures, or that there are no procedures for 185A. And the elements I have underlined in the regulation, all of those elements must be covered in your policies and procedures for the accountability of medication and controlled substances. And make sure you know where this procedure is. I've done inspections before where I go out and they know they've got these procedures in writing, but they can't find them. Well, that tells me one thing, at least, that they're not really used if nobody knows where they are. But it's important to have them and have access to them and make sure they're detailed so people can refer to them and use them for what their intended purpose is. An additional violation I have here, not following or implementing the procedures. Sometimes you have the procedures set, but they're not being followed or implemented. Insulin or other medication is not dated when opened, when the manufacturer specifies to discard X number of days after opening. Sometimes we see that we don't know how long it was open, and neither do you if it wasn't dated, unless you can figure that out and trace it back to when you received it. And it's pretty difficult. I don't know if that's possible, but when we see that, we often cite it under the 185A because you're not following the policies and procedures regarding accountability of medication. Also, medication requiring refrigeration is not refrigerated, or vice versa. Glucometers are not calibrated, which could cause incorrect data readouts. Not documenting glucometer readings according to your procedures. not following procedures to investigate missing medications or to investigate a med error, and not following narcotic or controlled substance count procedures, not having a prescribed medication available in the home for a resident. And those are just examples that I was able to think of regarding this regulation. And also there's a wide variety of things that would fall under this regulation, and that's why, you know, there's a number of violations that could happen. And Israel, do you want to talk about best practices?
We have a wide variety of items here, and time said I could talk the ears off a billy goat, so I'm going to try and be as use as little time as possible if we can, so we can get to everybody's questions at the end. One thing that I would like to touch on is a lot of homes are now assigning someone to make sure that when insulin is opened, especially on the Novolog pens or Lantus, the long-term insulin, that you put the date on there. Why? Because these items, even though you don't have to refrigerate them, will, after 28 days, Novolog is usually just like water. Lantus is it's a little bit longer, but the one thing that's important is some individuals, if they're on a sliding scale, may require more insulin or less insulin, and at that 28-day period, you're giving them something that is not effective. So you want to make sure that date is there so that your staff is aware and can dispose of it once it has reached that threshold date. Another one is the glucometers not being, how can you say it, calibrated. A lot of times when we come into your homes and we try to compare the MAR with the glucometer, if we have a reading that is not showing up on the MAR, a lot of times, especially if you have an EMAR, it only allows you to enter in those items which have been prescribed, those readings that have been prescribed. And you need to make sure that you have in place some type of tool that would allow you to record those extra readings. Because when we come in, we like to be able to verify that those readings are accurately for that individual and not from somebody else's glucometer. Therefore, we ask that you best practice that a lot of homes now either keep a log for the extra readings, or if they have an EMAR, they enter them into the system as an exception, and they'll show up on the exception report. Also, if they have a manual EMAR, one that they handwrite on the back where they put refusals or exceptions, they documented the items there or in nursing notes. What we'd like for you to do is to understand that what we're trying to do with that date and time, we're able to track those items down rather than not being able to give you credit for something that you've already done. What is important is that you make sure you follow your policies and procedures. And once we come into a home and it is discovered as a violation, then determine if retraining is necessary. And what you do is retrain those individuals and then put them on observations. And if you see that they still cannot follow those procedures and instructions, then you need to make a determination as to, are you going to allow them to continue with medications?
And, you know, having really detailed policies and procedures are very important, and using the policies and procedures, having them available to staff when they need them 24/7. So, you know, if they have a situation, they know what to do. For example, if it's determined that there could be some medication missing, and they need to investigate what happened to the medication, or if there's a med error, they should be able to look in the policies and procedures that you have and find out exactly what they need to do. And, you know, having good training and regular training on the procedures is very important as well. So staff are aware. that the information is in the procedures and they know what they need to do, and also why it's important. As an example, documenting the glucometer readouts correctly is very important, because they should understand that that could lead, if they don't document correctly, it could lead to somebody receiving the wrong dose of insulin, which could be life-threatening. So a lot of these things that are required, the elements that are required by this procedure, are very important. Also, doing your NARC counts, that process, your home's process for counting the controlled substances, narcotics, should be spelled out in your procedures so staff know what they're supposed to do. And then it should be followed. It should be followed regularly as required by your procedures. If it's not, that could lead to other things and potentially violations, and a lot of things can go wrong there. And then the quality assurance aspect, having specific people responsible for regular reviews of different things that are happening, medication administration, reviewing the MARS, checking the glucometers. You can check the glucometer readouts just like we do. Making sure you document all of the readouts, including the extra ones, as Israel was saying, also helps you to make sure that everything's going correctly with the glucometers and that they're not being shared and all the information is being recorded correctly. Good quality assurance on that is very important.
Yeah, I recommend heavily, as far as best practices, that it isn't simply that you're not just doing your observations, 2 times a year, but you're actually doing anything that has to do with medication administration, that's part of your QA process on a month-to-month basis, because you're striving for a hospital level of quality in these areas.
All right, moving on. Our next regulation is 141A, Resident Medical Evaluation and Healthcare. And regulation reads, a resident shall have a medical evaluation by a physician, physician's assistant, or CRNP documented on a form specified by the department within 60 days prior to admission or within 30 days after admission. The medical evaluation must include the following, and I'll just go through them: a general physical examination by a physician, PA, or nurse practitioner, medical diagnosis including physical or mental disabilities of the resident, if any, medical information pertinent to the diagnosis and treatment in case of an emergency, special health or dietary needs of the resident, allergies, immunization history, medication regimen, contraindicated medications, medication side effects, and the ability to self-administer medications, body positioning and movement stimulation for residents if appropriate, health status, and mobility assessment updated annually or at the department's request. And my examples are on the next page. I listed some that I commonly see: medical evaluation done prior to 60 days before admission or more than 30 days after, so being out of that time frame. Medical evaluation not done at all. The DME form, documentation of medical evaluation, is not signed by the medical professional, and that the medical evaluation wasn't documented on the DME, perhaps on the MA51, but not the DME. Well, that's not the department's form for personal care homes. Or the DME is missing one or more of the required elements. And this is a common violation because, once again, there are a number of things that could be missing or things that could go wrong with this regulation. A number of things could be missing from the DME, or it could be out of compliance with the time frame. And Israel, do you have best practices to talk about?
The biggest thing that I have seen where we're dealing with the DME is that the DME is not completed. Understand all the documentation on that form is essential to make a complete determination as to whether or not you can actually meet the needs of that resident. Understand when we come in, we have timelines for this particular form. And how we determine those timelines, one will be by the date of the evaluation. Understanding that if you have a change of condition, you will have to get a change of a new DME. However, let's say you get a change of condition and you get a new DME, that annual date starts from the date of the most current DME, which means that you're not getting one, say, in January, and you got another one in May. Now you're getting another one in January. The annual is not due until the date of the most current one, which was the one that you received in May. Understand all of that documentation, when we look at it, will help us determine that, coupled with the pre-screening and the rest, all of that information, we will determine if we can see that you're able to meet the needs of that resident and that everything falls into place. So please make sure all the documentation is there. If you receive it back from the doctor and it has not been completed, send it back to them, but make some type of note in the resident record, so if we do happen to come in, we see that you have already gotten the form, but it was not completed, and you send it back to be completed. And if you will edit it, make sure it's completed before you file it away, then when we come in, we don't see the blank forms.
Do you want to talk a little bit about the date of admission versus maybe the date the contract is signed, if it's a different date?
When we talk about date of admission, it's the date that they are physically in your home. You have some situations where a family member comes in from out of town and they come in before the actual date that the person comes on site, and they sign the contracts or they fill out the paperwork. Understand, we are looking at the date that they actually physically come into your home as the actual date of admission. And that is the date that we will be looking to see if the DME is within 30 days after that date or 60 days, no more than 60 days prior.
So what do you see homes do who are successful at making sure that say that all their medical evaluations are always done and they don't miss any? You know, what kind of quality assurance process would they have to make sure one isn't missed?
What most of them do is they actually have someone that is assigned, whether it be the director of wellness or someone designated in their medical, like an RN or LPN, that will review those forms when they come back in from the doctor to make sure they're completed. And also what they will do is they actually do have documentation either in a tickler file or in the resident's record charting the progress of making sure they get that form back, and it's not, if it's incomplete, return to the doctor, put the date, and put a follow-up date on the calendar for them to check to make sure that it comes back in. By having someone designated to do that minimizes the possibility of a form not being returned from the doctor timely, and also prevents the form from not being completed.
Okay. I think it would also be helpful to have maybe a second set of eyes review the DMEs before they get filed away. Say you have somebody responsible for making sure they're complete, that you receive one, you receive it timely, and that everything's covered in the form, everything's filled out. That person could perhaps have a second person if your home has that, the ability to have another person take the time out to take a look at these before they get filed away, to make sure that they are complete and don't have any blanks where we're missing information. you have anything else on that one?
Oh, no, I'm good.
Okay. Moving on to 187D, medication records. The home shall follow the directions of the prescriber. Examples are if you're not, the administration didn't happen of a prescribed medication, medication wasn't administered as prescribed, or the incorrect dose was administered, or at the wrong time, or not following special instructions for administration from the prescriber, or not following any special precautions that might exist for the medication, such as not giving the medication at a time, the wrong time, because it could make somebody drowsy, or not giving the medication with food, or vice versa, whatever the instructions are. Israel, best practices.
Yes. In this particular aspect, when we talk about 187D, this is where your policies and procedures are very important, and ensure that your staff are following your protocol to the letter. You have to help them to understand that when they're given medication, try to make sure that they're only serving one resident at a time. A lot of times when you talked about a lot of errors with medications, or you're trying to service more than one resident at a time, and you get the medications mixed up, or you're hurrying and you're not really focusing on that particular item that you're working on. That's why you have to understand one at a time and try to keep everybody, because everybody wants their meds at one time, but try to be patient and make sure that they're following your procedures and protocol, and that they're not taking shortcuts, because normally when they take a shortcut is when something usually comes to pass. This is one of those items where you make sure that they're following the medication training, and two, anything that happens out of the unusual, that they do have someone that they can go to for answers and resolve that issue before moving to the next one. So make sure that you follow your procedures, take their time, and just focus on one resident at a time.
All right, and Israel mentioned about having policies and procedures for 185A that we already talked about. Having good, robust policies and procedures for the safe distribution of medications is very important in making sure that the medications are administered as prescribed, and having regular training on the policies and procedures, ensuring staff understand what they're supposed to do, and the importance of doing it the way that's required. Also, quality assurance is key here. Reviewing MARS on a regular basis and observing medication administration to ensure the prescription orders are followed, and taking corrective action and retraining staff when necessary. I understand the medication training they reduced the requirement for the MAR reviews and the observations, but that's for the training purposes for the medication administration training certification. As far as your home goes, it's good to have specific people in charge of reviewing the MARs and observing medication administration on a regular basis to ensure it's being done correctly according to the home's procedures. And then reviewing the MARs to make sure they're correct according to what was prescribed, so it will not cause a med error. Sometimes I see that the MAR could be incorrect as far as maybe the dosage on there, or the regimen for the medication could be incorrect according to what's actually prescribed. So you want to make sure the MARs are correct, and also making sure the medication labels are correct. Sometimes we see that the medication label has the wrong dosage, and the actual doctor's orders are different. So that could also cause a medication to be administered incorrectly. And also ensuring the medications are ordered and received so the dosages will not be missed, which goes back to the procedures. Having good policies and procedures regarding the safe access of the medication, ensuring that you have the medication available in the home is very important as well. If the medication is not there to be prescribed, well then, you're not following the physician's orders, the prescriber's orders. And often people ask whether if it would fall under this regulation when somebody refuses a medication, but that's, I guess, a different situation. When somebody refuses a medication, it is not administered according to the prescriber, but that wouldn't be a violation of 187D following the physician's orders. I mean, there's other protocol that you go through under those circumstances with documenting and contacting the physician and making sure you know what to do when somebody doesn't want to take their medication or refuses their medication. All right. Is there anything else you guys have about that one? And the next one, which is our final regulation, is 187A, medication records. And the regulation specifies a medication record shall be kept to include the following for each resident for whom medications are administered. And that includes resident's name, drug allergies, name of medication, strength, dosage form, dose, route of administration, frequency of administration, administration times, duration of therapy, if applicable, special precautions, if applicable, diagnosis or purpose of the medication, including PRN, date and time of medication administration, name and initials of the staff person administering the medication. And I have some examples of violations under that regulation. The MAR is missing one or more of the required elements. There are 14 that should be missing. One or more of the elements on the MAR is incorrect. Staff documents incorrect date or time of administration. Staff doesn't document a medication administration. The medication administration documented on the MAR, that didn't happen. Or staff documents a medication administration on the MAR that was administered by another staff person. So this one also goes back to the policies and procedures for safe distribution of medications. Having good policies and procedures can help to avoid things going wrong and getting violations. Having regular staff training on the medication procedures and quality assurance. Israel, best practices, do you have any that you could suggest for the 187A?
As with any medical, any of the violations that can be occurred for medical, when you're dealing with medication, it goes back to having that extra set of eyes. A lot of individuals, when they get their MARs, they come in from maybe the pharmacy, and a lot of times they're filed away without reviewing them. We're finding that some pharmacies don't put the diagnosis on there, and that's one of the required items. Some are now using barcodes or scans to put all of that information on, I guess trying to upgrade HIPAA, but understand we still have to see that information on the MAR. What you need to do is make sure that when you do get your MARs in, that you review it to make sure all the required elements are there. Also, make sure that there are any changes. Check the orders from the physician to ensure that there are no changes from medication that you have currently in stock. If there is a change in the medication, be sure to put a sticker on the bottle or the container for the medication saying refer to MAR for the most current order. That's about all I have.
Okay. And I'm just going to go back to the policies and procedures and the training on the policies and procedures, ensuring staff know what to do. Also, the quality assurance, having one specific person or specific staff people responsible to review the MARs when they come in, and then on a regular basis to make sure everything is being documented correctly, or that all the required elements are there, such as diagnosis and purpose for the medication that we often see that's missing. To make sure the staff have been documenting it correctly as they go along when they administer the medication. They should be initialing when the medication is administered. We all know that, but we often see where it might get missed. So these things should be checked regularly by specific people who are responsible for checking that and making sure any corrective action or retraining is taken with the staff. Sometimes people make mistakes, or they start doing things a certain way and they don't realize it's not the right way until somebody tells them that they should do it another way. So retraining and regular training on specific policies and procedures for the safe distribution of medication is very important. Okay. And those were the top 5. I don't know, we probably could have done maybe 2 more in this hour. But I put a summary here. After putting this PowerPoint together, I realized there really was a common theme for these violations, for the best practices in avoiding the violations. And it really, comes down to having the detailed and thorough policies and procedures, especially for 185A, and making sure everything is covered in the policies and procedures and that it's clear, and staff would be able to refer to them to know what to do, and everything's spelled out in there. And having regular staff training on the procedures on a regular basis. I mean, one time is not enough, and I know you have to have your annual training, but it's good to have training regularly, especially if staff don't understand something, or something's not real clear, or they're having issues with a certain area of the regulations, the policies. And making sure the procedures are understandable and available to staff. Making sure the staff understand why the procedure is in place and its importance for the resident care and safety. Going back to the example of the sharing glucometers, it might be convenient to use the same glucometer for more than one resident because you get it out of the glucometer and you might feel it's convenient to test more than one person with it, but understanding the importance of not doing that, the fact that you could spread disease, there's bloodborne pathogens that could be spread when you use those practices. And if they understand that, and what has happened in some homes where hepatitis was spread, and it was traced back to that practice by the CDC and the Department of Health. If they understand that, then maybe they'd be less likely to take a shortcut. And my final bullet there is quality assurance. With all of these regulations that are commonly cited, quality assurance can help to avoid them as well. Regular checks, having specific staff people responsible to check weekly, monthly, daily, whatever's necessary for the specific item that needs to be checked is very helpful in making sure that you catch any problems and you have a chance to correct them and retrain staff to make sure that it doesn't happen again.
Yeah, and one of the things that that I like to just add to this in terms of the QA issues is we use these 5 typical kinds of violations because they are the top 5. Maybe you know that within your own particular facility, you've had other areas which have been weaknesses or concerns for you. And as you go through your QA process, you can either use these top 5 or any areas that you know that you've had some violations or issues in the past. And you can do kind of like a monthly, you know, almost like a little mini evaluation or inspection of your own and go through and see how many things that you come up with. And that keeps you fresh in terms of being able to use best practices to help improve your quality overall. I think that's always a good thing to do on a monthly basis. Actually use it as though you were doing a mini inspection yourself. And you can take certain areas like the medication administration, because obviously from what we're showing you, medication administration is a huge area where if there are weaknesses, that's oftentimes where it shows up, but also cleanliness and some of the other forms such as the DME and the RAS.
All right, and also the regulatory compliance guide has additional information. And I know many of you use the RCG and some of you aren't as familiar with it, but it does have a lot of information in there about each, certain regulations. Ones that are commonly cited or we have a lot of questions about have more information, but it's good to take a look in there and find ideas to maintain compliance as well. All right, and now, we have a lot of questions that have come in that we're going to cover. I have the operator support hotline up on the screen along with the email address that would also go to Dale Crow to answer questions. So I guess we're going to go through the questions now, and if you have anything additional after the webinar or anything that's unrelated, you can go ahead and send it to, give Dale a call on the hotline or send it to the email address on the screen. So we want to start going through those?
Well, some of the ones that came up that have to do with the DME, can a nurse practitioner fill out the form? We now have residents who have a nurse practitioner as their primary practitioner. Yes, you can do that. Also, physician's assistants can do it. Not a CNA. Readmissions of a resident from a hospital to a prior level of personal care and with no new diagnosis is a new DME required. This comes up with some frequency, actually as a hotline question. And when you're talking about the same level of care and same service provision, the answer is no. You don't have to redo your DME. The main question is, coming out of the hospital, are there new service provisions that are required? And that may require an addendum or an update to the RASP, not necessarily the DME. If a level of care changes, if the person has an addition of a new service, like for example, even if there is a new diagnosis, but let's say the diagnosis was hypertension, high blood pressure, well, maybe it does require an update of the RASP because perhaps the person is going to have to be on a low-salt diet. Maybe there's some other changes that are required, but that doesn't necessarily mean they need a new DME.
Okay. Those were the only questions? I thought we had more.
No,
No.
you got,
okay.
you got a bunch of them.
All right.
Two.
Okay.
Those had to do with the DME.
All right.
Oh. One question is, can you discuss the main violations for over-the-counter medications and more documentation for self-administered over-the-counter medications and self-administered over-the-counter medications? If you have someone that's been assessed to be able to self-administer their own medications, a lot of times, a lot of homes do not record when the medications are taken because the individual usually keeps their own medications in their own room and they are responsible for taking that medication. Now, the difference is that when you have a staff person giving an over-the-counter medication falls into the same realm of any prescribed medications. You have a third person giving someone medication, and it's documented what medications were given and usually what time that medication was given. So over-the-counter is totally different if administered by a staff than a individual doing their own medications. When we come in, if the staff is giving that over-the-counter medication, we expect to see the same documentation that we would see if they were given a prescribed medication. Most cases for over-the-counter medications, you won't find that documentation for someone who self-administers. Now we have a question that says, in regards to glucometer calibration, shouldn't the glucometers be calibrated with control solution before every change of glucometer strips? Most models, one, usually ask that you do that for sanitation purposes. It doesn't matter if and that does not alleviate each individual having their own glucometer. It is not, some homes do not do it after every strip. However, what you should do is follow the manufacturer's directions on cleanliness in that particular aspect. A lot of glucometers today do not require coating or recalibration, but they should be cleaned regularly after each use to prevent any type of bloodborne pathogens occurring.
Now, what she was asking, or her inquirer was asking about calibration?
Yeah. Calibration, most of them current ones are, you don't require calibration, but you're talking about cleaning also after each strip, because they were talking about the cleaning strips.
But I think they're asking about, should the glucometer be recalibrated with a control solution before every change of glucometer strips? I don't know if they're asking about sanitation.
But if they're talking about that, no, you just follow the instructions of the withdrawal, and that's, normally you don't.
Right, I think it depends on the manufacturer's instructions.
Is it acceptable for personal care to obtain meds from an emergency medical supply in the skilled nursing facility? No.
I think that is mentioned in the RCG.
Mm-hmm.
Want to find that? You want to move on to another one?
Yeah. Narcotic counts. Staff person that count and records the narcotic count. Does the staff person have to be medication administration trained staff? They would not be administering medications. They would only be counting and recording on the midnight shift. Preferably, yes.
I'd say it's recommended that the person be trained.
Yeah.
I think technically they wouldn't have to be.
No.
But,
It'll be to your advantage.
right, it would be definitely the best practice to make sure that is a trained staff person, in handling the medications.
And the next part of this question was, how many days does the home have to complete a DME for a SDCU resident returning from SNF rehab stay at the facility? If this is a resident that is currently a resident of yours and they haven't been discharged from your home and they are just there for rehab after a hospital stay, etc., usually a DME comes back with them. If not, it'd be to your advantage you want to make sure that you have a current representation of that person's health status when they come back into your home to ensure that you can meet their needs. If they never have been a resident of yours, then you need to go to 2600-231G, because that individual must have a diagnosis of Alzheimer's, and it falls into 60 days prior, 30 days afterwards. Now, you do have individuals who can stay in an SDU that does not have an Alzheimer's or dementia diagnosis. However, they must understand that they are there and you sign the proper documentation.
Okay. You want to go back to that question that I was looking up? Medication machine stuff.
Yeah.
Okay. Okay, the question is it acceptable for personal care to obtain meds from an emergency medical supply in the SNF? And what I was thinking of in the RCG is under 186C, that has to do with changes in medication. But there's a notation in the compliance guide that says it is permissible for the homes to use emergency medication system machines. However, these machines are permitted if they are accessible to licensed nurses only. Licensed nurses which are RNs, LPNs, must manage the ordering of the emergency doses, and direct care staff should work from written order provided by the prescriber or the information written onto the MAR from the nurse taking the verbal order. But I think maybe we could answer this later, but from what I understand, if this is a CCRC, I don't know, Israel, correct me if I'm wrong, but if it's a CCRC and it's registered nurses or LPNs who access the machine, say, it's a connected nursing facility or just a personal care home that has a nursing facility attached, then I thought it might be possible for them to do that, but maybe we should double check.
Let's research that more further.
Yeah, just to make sure, because I don't know if that's a gray area for us, but we'll check on that one for sure and get back to the Inquirer.
Our facilities use nurses to check glucometers daily. The nurse cleans the glucometers per manufacturer's instructions and perform quality control. Part of this process is to check the glucometer readings against MAR. The nurses had been erasing the readings on the glucometers after the checks were performed and documented. We were told at an inspection a few months back that we're not permitted to erase the glucometers after they have been checked by the nurse and the check documented. I'm not sure I understand why, if it is a licensed professional checking the glucometers. When we come into your home, the way that we validate whether or not a glucometer is being utilized by multiple individuals is by comparing that glucometer to the MAR. And in order to do so, we're going to have to be able to compare the readings that are there. Now, you do have situations where you change a battery and the glucometer readings, some units automatically delete the readings that you have saved when you change the battery, or you have an issue where it's dropped and the battery comes out. You need to document that, because when we come into the home, we're going to be looking to see readings on the glucometer. We have to compare that to the MAR to ensure, that's how we ensure that it's not being shared. And if there are no readings on the glucometer, we cannot validate that the readings that you have there are valid for that glucometer. So please don't erase those after you've verified them, because we have to compare that glucometer to your MAR. That's part of our review when we come into your home.
It's not only important for us to be able to review that, it's also important for you, for quality assurance on your end in the home, to ensure the readouts are correct that are being documented. So, you know, if you have quality assurance process where you're checking on these readings to make sure everything's being documented correctly, you're not going to be able to do that if the readouts are being erased.
Okay. In regards to glucometers, if there is a glucometer that all of a sudden doesn't work, how do you handle that? I understand not sharing glucometers and sanitary conditions. However, if there is a newly broken glucometer, what do you do? Not use the glucometer and therefore not administer the insulin. Part two of the question, if you would check a blood sugar for a nursing measure, but the resident doesn't have their own glucometer, what do you do? All right, this was a multiple one. Number one, a lot of homes today keep a few glucometers in stock. And the purpose for that is because that if a glucometer goes out, the first thing you would do is to call the primary care physician to inform them of the difficulty that you have. And then you would notify them if they're on a sliding scale, do you prescribe the insulin, or can they miss the insulin for that particular time until you get a new glucometer? Now, a lot of places are able to have new glucometers on stock, and what they do is they use that glucometer and assign that person a new glucometer. If you don't have one in stock, some physicians, I'm not saying all, some physicians will allow you to miss long as you can get a glucometer in-house as soon as adequately possible. We don't want people missing medications. We don't want people sharing glucometers, but what you might want to do is have a few on hand, and as needed, put it in play, and then when a new one comes in for that individual, replace that in the stock that you have. A lot of homes try to use the same glucometers coming from the same source, and that is the best practice because it makes it easier for your staff to understand how to maintain them. Now, if you have an individual that does not normally have their glucometer or their sugar checked, and they don't have a glucometer of their own, again, you can't share. You're not supposed to have a home glucometer. What you need to do is make sure you have a few on stock, and if that person needs one, then you assign them that one. Even though they may not have them on a regular basis, that becomes their glucometer to be used by that individual going forward. And then what you do is replace your stock. Unfortunately, you cannot have a house glucometer and not, even though that person may not have regular readings. There are no exceptions. Can you review, again, best practice for documenting extra readings with glucometers? what you have there is, like I said, that a lot of individuals, what they have is that on their MARS, it only allows for recording what is ordered by the physician. Therefore, one, you can have a log where you record all of your extra readings, or two, you may actually document it in the progress notes in the residence records. The ideal would be to, if you have an EMARC, enter them as an exception. Put in, because it will bring in the date, just put in the time and the glucometer reading. Or if you have a manual MAR on the back where you write your refusals or exceptions, you would document that extra reading. Again, what you want to do when we come in and we compare the glucometer, when we look at your MAR and we see that there's extra reading, if you have it documented somewhere, we're able to better verify that there is no sharing going on. So what I tell people is, whenever in doubt, give us a shout. Pick up a phone, give us a call, and we'll give you that information. Understand our job is to help you become compliant. And we want to be your partner, and we want to work with you. And communication is very important. Not only when we're here or when on the phone, when we're in your home and you have questions like this, please ask us, and we'll find that time to talk to you, because it's a lot simpler to fix something before it happens than after it happens. Question says, can you set the same set of controls when calibrating the glucometer if you have multiple meters?
I don't understand. Do you understand the question?
No, this one I don't. You know,
Can you read it again, and we can ask the person to
saying,
clarify?
can you use the same set of controls when calibrating the glucometers if you have multiple meters? Give a little bit more.
Yeah.
See if they can resend that with a little bit more detail.
Yeah.
And so, do we need an order from a physician for over-the-counter medications? I always say preferably, because you want to make sure that that over-the-counter medication does not conflict with prescribed medications that they're taking. A lot of times, some of the homes that I go into, and I'll be honest, they don't have a order from the physician. However, they have documentation that they have conferred with the physician that is okay for them to take that medication, and it does not conflict with what they're taking. What I always tell people, the best thing to do is to have something on file when we come into your home, because it makes it a lot less explanation for your staff when we come in. So it would be to your best advantage to go ahead and have something in file showing that it's okay to take that over-the-counter medication. That's a good question. I'll find out for you. Okay. What else?
Well,
What?
There's one that residents who self-administer medications, do all medications have to be locked in a container or a locked medication cabinet? That depends when you're talking about self-administration. If they're completely self-administering, meaning that they have complete control of the medications in their room, as long as their room is locked, they're okay, unless the person has a roommate that is not approved for self-administration. Then they cannot lock them in their room. Because they can be defined as self-administration and still have their medications locked in the general medication room or in the med cart, and just simply come in the morning and take their medications on their own. Whereby, if you have their medications, then yes, they must be locked, but they can still come and get them from you and still be defined as self-administering.
Okay, if a resident is sent to the hospital and out of the facility during the time their annual DME is due, should we still complete the annual DME at the time while the resident is on leave, or wait till the resident is readmitted? This is one that I have fallen into quite a bit in all my years of doing this. A lot of times when a person goes out to the hospital, they usually get a new DME because they're assessed while in the hospital. What I always tell people, it will be to your best advantage to wait till that one comes back. You don't have to have one done before they come back. And make sure you document when we come in the house that the individual is hospitalized, and that's the reason for the delay. And we do understand, we do take that into consideration because they're in a medical facility being assessed and treated. Therefore, a DME usually comes back with them when they come back from the hospital. Therefore, it's not necessary for you to get one and then get one before they are discharged from the hospital. All right, is it a violation if the medication didn't arrive from the pharmacy in one day, but the doctor is aware that the resident didn't receive the medication? What's important is that you have to make sure that the family and the physician is notified that the medication is not in the home. Now, if the medication is not available for the individual when we first come in, when we're in the home, and it's not available for usage, yes, there usually will be a violation assessed. However, say if it's a new medication that is prescribed and it has not been filled as of yet, that is taken into consideration. Therefore, I always tell people this is a case-by-case situation, depending upon all the circumstances. So there's not a concrete yes or no. It depends upon the circumstances, and we take it by case by case. Dude. Okay, question 142A2 specifically, number 7 states medical evaluation must include medication regimen, contraindicated medication, medication side effects, and ability to self-administer medication. Is there further explanation on the medication side effects? There is no specific section to place this on the DME. This one I will take the time to research for you, because the answer I will give you right now is convoluted and would not get to the specific question that you're asking. Therefore, let me research this and tailor an answer specifically to the question that you've asked here.
Again, I'll give Israel a break on one here. If a resident self-administers and has narcotics, do they have to have a lockbox in their room for the narcotics? Again, we don't think they do if they're living alone. They have to have the room locked. However, if they have a roommate, and even if their roommate is approved for self-administration, then they would have to have a lockbox if they have narcotics in their room.
And that should be in the procedures under 185A for the safe storage of medications. That if it's not specifically a regulation that you have to have a separate locked box in the room, even if you're locking your door, but it would probably be something you'd want to put in your policies and procedures for 185A, that you would want to do that. I mean, it would be advisable, I would think.
Okay. If a resident is seen by a physician a couple of weeks prior to admission and get their DME completed, then what is the date the assessment can be finalized? And you ask the question 15 days after the date of admission. That the date of admission is the date that drives the RASP. Okay? The date that they come into your facility and is admitted is the date that drives your RASP. So that is the date that your 15 days begin. Okay. Any highs and lows? Oh. Each finish has its own control fluid. Okay, you're talking about can you use the same highs and low solution for multiple glucometers?
And that's like a follow-up on this
Yes.
question? Okay.
What I always tell people is that most glucometers come, each manufacturer send their cleaning solution or their glucometer solution with it. This is one I always say, read the manual, because you want to make sure that you are following the instructions for that manufacturer. Therefore, if they're not the same manufacturer, then I would show some reluctance unless the instructions for the manufacturer says there's no problem in doing so. So I would do so with reservations after investigating and reading the manufacturer's instructions.
Okay, we have a question. Can you tell me what diet manual you refer to for diets that are listed on the DME? And then it says LIE, heart healthy. But I do know that we have something we can recommend, but I don't know it off the top of my head while I'm here. So we can get back to that person. Do we have more?
I have one here. Let me see your
Okay.
Tomorrow, racing.
Okay, we're looking one up right now.
Said, what violation is cited for erasing glucometers? What you're looking at right there is going 2600 185B, and if you go down to number 4, it's documentation of the administration of prescription medications over the counter and CAM for residents who receive medications and services or assistance with self-administration and so forth. Well, the requirement does not apply to residents who self-administer medications without assistance of staff or stores. But you're talking about documentation for the administration of a medication. That's why it will go under 185B4.
And it could be also that their policies and procedures under 185A should cover the use of the glucometer, and perhaps it would be written into that procedure that you're not going to erase, that you're going to keep the information in the glucometer and then document it correctly. I don't know if something could potentially be cited there if it's if the procedure is not implemented correctly. But that's that's an important thing to keep on record.
Okay. We have regarding the RASP and 15 days, are you counting the day of admission as day 1? Yes, that is the date your services are beginning for that individual. Usually what you're doing in that, you're assessing them from the time that they are admitted, and you're utilizing the information that you obtained from your pre-screening to determine the services initially that you're going to be providing for the individual. And from the time that they come into your home, you're assessing how the accuracy of that information, and do you have to make any changes in what you need to do to provide services for that individual. So it starts from the time that they are admitted into your home, and usually it goes within those first 15 days that they're there, yes.
So the question was about assessment?
Yes, it said,
Okay.
Do you count the first day of admission as day 1?
So if say somebody is admitted on the 1st, their assessment must be done by the 15th. That way we look at it.
Yes.
Okay.
And normally what we do, you have situations where an individual, let's say you have an individual who something happens and they have to go to rehab or they're sent out to the hospital. Understand, we don't expect you to have, if that happens within those first 15 days, we don't expect you to have that RASP completed at that time because you haven't finished your initial assessment of that individual. Therefore, there are things that you take into consideration. But barring no unusual happenings, yes, you usually count day 1.
Okay, do we have any more?
Yeah. We're asking here, the DME is due annually, yes. Does a resident have a 15-day grace period to be seen by the provider? Yes.
On the annual.
On the annual, yeah.
Not on the initial.
Because sometimes, as I've been told, the provider makes their date ahead of time. However, on that date that it's coming due, they call you and tell you they're going to be out of town, something else has come up, and they can't get it in within the 365 days. So yeah, you do in that case have a 15-day grace period. you're asking or you're telling me that the insurance company doesn't cover 2 in 1 year. That's oftentimes true if it is an annual. If it's a new episode of care, they will cover 2 medical examinations. I'm not sure what the question is actually on that, other than yeah, that can be true. So you have to be kind of careful as far as how you plan out your medical evaluations, the annual ones.
Is that the last question?
Yeah, I think except these were ones I believe that you were gonna check on, I think.
No, this one I just answered.
The answer, okay.
Just answered this one.
Both of these?
Yeah. Okay. And we talked about the best practices.
Okay.
For
Well, I have 2 that we're tabling that we're going to get back to people on. So we will be in contact with you. Also, if you have any other questions, feel free to reach out to your regional office or to our hotline that's on the screen or email address, and Dale will get back to you, or if he doesn't know the answer, he'll research it and get back to you. So I guess that concludes our webinar for today. We took almost exactly an hour and a half. I'm sorry, Dale has something to say.
Well, just one more reminder that if you stayed on the entire time, you will get 1.5 CEUs. However, you will not get a paper certificate. That you just simply log your time as you would other trainings that you go to.
All right, well, thank you everyone for joining us today. Please feel free to reach out to me as well if you have any other ideas for training topics or things that you need clarification on, or you feel the provider world would need training on. So thank you very much for joining us today. Have a great afternoon.